Hi. Alright, future midwives. Today we are tackling gestational diabetes, or GD. As I like to call it, when the placenta becomes a sugar dealer. But before we start freaking out about big babies and insulin resistance, let's go back to the basics and understand what's happening in the body. Before we jump in, quick question. Do you remember how the body normally handles sugar? If it's been a while since you thought about metabolism, don't worry, we're starting with a refresher. So, let's talk about carbs, because they're not just delicious, they're also the body's main fuel source. Think of your body like a wood stove. Carbohydrates are the quick-burning firewood, that fast energy. Fats and proteins are like those slow-burning logs, backup fuel. Insulin is the person adding the right amount of wood to the fire so that it doesn't burn too hot or too cold. So, some key metabolism breakdowns. Carbs break down into glucose, which is a simple sugar that fuels the body. The pancreas releases insulin, which acts like a key to let glucose into your cells. Glucose fuels the body, and anything extra gets stored in the liver as glycogen for later. If glucose runs low, the liver converts stored glycogen into glucose. If no food is available for 12 or more hours, the body breaks down fat and protein for fuel, which produces ketones. So if glucose is fuel, what happens when the body can't use insulin properly? That's where gestational diabetes comes in. So what happens to metabolism during pregnancy? So pregnancy is basically a metabolism hack. Your body changes how it handles sugar to make sure that the baby gets enough nutrition. Imagine the placenta as a traffic controller. It slows down insulin so that more glucose stays in the bloodstream for the baby. But sometimes the traffic backup gets out of control, and that's where we end up seeing gestational diabetes. So, key changes in pregnancy metabolism. You have your placental hormones, such as estrogen, lactogen, and progesterone, which reduce insulin effectiveness, meaning that more glucose stays in the blood. Then you have the pancreas compensating by making more insulin, 2 to 3 times more than the normal amount. And then blood sugar naturally stays higher after meals, especially in the 3rd trimester. The fasting glucose levels actually go down as the baby uses more glucose between meals. So if pregnancy naturally makes insulin less effective, why do some people develop gestational diabetes while others don't? Let's find out. So, gestational diabetes happens when the pancreas just can't keep up with all of the changes in pregnancy. Blood sugar gets too high for too long, and that can affect the baby's growth. Think of the pancreas as a warehouse worker trying to move glucose boxes into storage. If the doors are sticky, insulin resistance, and there aren't enough workers, not enough insulin, the boxes start to pile up in the bloodstream. Now, GD isn't the same as type 1 or type 2 diabetes. It's temporary, and it's specific to pregnancy. Risk factors include family history, previous gestational diabetes, carrying extra weight, and a high-carb diet. But false positives happen. Some people fail the glucose test, but actually have a normal blood sugar at home. So what do you think is the best way to test for gestational diabetes? Let's talk about the options. So the most common test that we have is the glucose challenge test, or the GCT, which is basically a stress test for your pancreas. It's like handing someone a giant sugar bomb and seeing if their body can clean up the mess fast enough. So, testing breakdown. The GCT, you get 50 grams of a sugar drink, pretty much a medical Slurpee, and then your blood sugar is checked in an hour. If it's high, you move to the oral glucose tolerance test, or the OGTT, which is 100 grams of a sugar drink and a 3-hour test later. So, what about some alternatives? Tracking blood sugar at home, A1C, which is a long-term glucose check, and a food-based challenge, eating a carb meal and testing afterwards. So why does gestational diabetes matter? Well, you can have potential complications. You can have a big baby, also known as LGA, or large for gestational age, which means a higher chance of birth interventions. You can have an increased chance of shoulder dystocia and possible birth trauma. Newborn low blood sugar, if a baby's pancreas overproduces insulin in the womb, and you do have a higher chance of type 2 diabetes later in life. But think of fetal weight estimation like trying to guess the weight of a watermelon through a foggy window. Sometimes it's accurate, sometimes it's way off. So how do we manage it? So our first line management is a balanced diet. Protein and fiber and slow carbs. Movement, about 10 to 15 minutes of a walk after meals, and monitor your blood sugar regularly. Aviva Jill Rahm's holistic approach is whole foods and nutrient-dense dieting and stress reduction, yoga, deep breathing, stuff like that. Managing gestational diabetes is like keeping a fire at the perfect temperature. You don't want it to burn too hot, high blood sugar, and you don't want it to burn too cold, low blood sugar. So let's wrap this up in the top 5 things that you need to remember about gestational diabetes. Pregnancy naturally increases insulin resistance. It's normal. GD happens when the pancreas can't keep up. Testing isn't perfect. Look at real-life blood sugar trends. Most GD cases can be managed with diet and lifestyle. And midwives focus on informed choice, not fear-mongering. And remember, the placenta isn't evil. It just wants to make sure that the baby gets fed. Our job is to make sure that it doesn't overdo it. See below to download your GD cheat sheet. Thank you.